Good morning, ladies and gentlemen. It's wonderful to be here at Geo. All nostalgic memories coming back of the 2023 National Conference here, which we had conducted. At the outset, must congratulate Purvi, Manoj, and their entire DRS team for the wonderful hospitality and inviting me to give a talk here. The topic given to me is Pioglitazone and its combination, type 2 diabetes and MASLD management. Basically, if you look at pioglitazone, it has got this trifecta effect. It treats insulin resistance, metabolic dysfunction associated steatotic liver disease, abnormal fat distribution, and visceral fat becomes subcutaneous fat, and all this has emerged as a very powerful tool in addressing the metabolic abnormalities simultaneously. Insulin resistance in Indians, is the phenotype different? In fact, insulin resistance is very common in Indians. We are an insulin resistant population. All studies all over the world have shown that Indians have the highest insulin resistance in any ethnic group. You must have all seen this. This is Professor Yagnik from Pune on that side and Yudzik from Austria here. Both of them have the same BMI. But look at the body fat. So this has become the thin, fat Indians. Indians are thin but more fat, but unfortunately that fat is more central. It's visceral. And if you see the Indian phenotype, you see the Caucasian, he's fat all over, jadya, absolute. But you see the Indian, his belly. When he enters the room, the belly comes first and he follows. That's a typical Indian phenotype. And insulin resistance, clinical consequences last. It is a cause for all those things. I won't go into the details. Now let us look at what are the implications of untreated insulin resistance. Increased risk of type 2 diabetes. Diabetes prevention studies have all looked at diet, exercise, pharmacotherapy. And in the pharmacotherapy, the glitazones have been the best, right from ACT Now to IRIS study, which showed reversal or prevention of type 2 diabetes. And this was Ralph DiFranzo's study, which said that the annual incidence of occurrence of type 2 diabetes in a pre-diabetic was 4.1% for lifestyle modification, 1.7% when it is pioglitazone and metformin, and no occurrence of diabetes when you have a pio, metformin, and a GLP-1. So basically, pharmacotherapy, non-pharmacological therapy does not work. And if you look at the ACE guidelines, that for pre-diabetic, if you're overweight, then you go for GLP-1 analogs, and now you have the coagonists like tirzepatide. But if you're just looking at a dysglycemic goal, then you have metformin, pioglitazone, and acarbose. Treating early. So progression of type 2 diabetes depends on the beta cell. As the beta cells die, you have less and less insulin, so blood sugars rise, and that is what leads to the progression of type 2 diabetes. These are studies using sulfonylureas. You see initial good HbA1c reduction for 1 to 2 years, and then the HbA1c begins to rise, which is suggesting that the beta cells are dying and insulin is becoming less. These are 8 studies using glitazones, good decrease in HbA1c, and it is maintained. What does that tell you? That the beta cell apoptosis probably slowed down or even prevented. And the main reason why this does is, if you look at the action of glitazones, there is a mobilization of toxic lipid metabolites out of the beta cell. Lipotoxicity is addressed, and that is how it prevents the apoptosis of the beta cells. Now let us look at the cardiovascular complications and the metabolic syndrome. Atherosclerosis, hypertension, dyslipidemia, and all these things. 80% of patients with type 2 diabetes have insulin resistance. These are few studies which show that insulin resistance itself is a major independent predictor of cardiovascular and myocardial infarction and stroke. This is the Nurses' Health Study. I won't go into the details, but what it tells you is that the elevated risk for cardiovascular disease begins at least 15 years before the diagnosis of diabetes. Let me repeat that. The elevated risk for cardiovascular disease begins 15 years before the onset of diabetes. So when you talk of treating diabetes, you're not just talking of glycemic control. It has to be multifactorial because there are other factors which are responsible for cardiovascular disease. Is there evidence that treating insulin resistance will work? For treating insulin resistance, you have diet, exercise, weight reduction. Pharmacological, you have metformin and pioglitazone. You now have the GLP-1 analog semaglutide, and you have the tirzepatide, and you have a retatrutide in the pipeline, and SGLT2 also is there. This IRIS study is very important. This was done in non-diabetic patients who had type 2 diabetes, who did not have diabetes, non-diabetic patients who had a stroke or a TIA. And they looked at the HOMA. If the HOMA was more than 3, they were insulin resistant, and they were given pioglitazone followed up for 5 years. And what did they find? That recurrent stroke reduced by 24%, myocardial infarction by 24%, and new onset of diabetes by 52%. And this was first time that any therapy which is directed purely at insulin resistance, nothing else. They were non-diabetics given pioglitazone to treat insulin resistance, and that was the benefit that was shown. But in this same study, there was a subgroup of population of 2,800 plus patients who were pre-diabetic. They were not diabetic, pre-diabetic. And when they analyzed that data, fantastic outcome. Stroke, myocardial infarction combined reduced 40%, stroke alone by 33%, acute coronary syndrome by 52%. Remember, these patients all have had a stroke. They were non-diabetic. And the outcome at the end of 5 years, acute coronary syndrome reduced by 52%, and new onset of diabetes reduced by 80% over a median follow-up of almost 5 years. So this study tells you the importance of treating pre-diabetes. The benefit of treating pre-diabetes is fantastic. So now when a patient comes to me with pre-diabetes, I don't tell him you're pre-diabetes. I tell him you're early diabetes. Treatment chalu karo. This is what is required. So your phraseology has to become different. So the American Heart and Stroke Association recommends pioglitazone for prevention of recurrent stroke. Cardiovascular risk factors and biomarkers, all these studies, Proactive, Chicago, Periscope, IRIS, and several meta-analyses have shown excellent results. The Proactive study showed a recurrent fatal MI by 28%, acute coronary syndrome 37%, and stroke by 47%. And it was this Proactive study which showed a 47% decrease in stroke, which prompted these neurologists to do this study with pioglitazone in the IRIS study. That will it prevent stroke? This is a Chicago study. Carotid intima media thickness comes down, means showing that it is anti-atherogenic. This was Steve Nissen's study, the one who killed rosiglitazone. It shows the atheroma volume comes down with pioglitazone, increases with glimepiride. But this is a very interesting study done by Helen Strongman, who looked at the European multi-database cohort study it was, where they looked at patients who took pioglitazone and patients who didn't take pioglitazone. 31,000 patients exposed to pioglitazone. And look at the deaths on patients exposed to pioglitazone and not exposed to pioglitazone, not exposed to 3 times more deaths, non-cardiovascular and all cause, 3 times more. So, and if you look at cardiovascular cause specific, myocardial infarction, again 3 times more in patients not receiving pioglitazone, stroke, heart failure. We say pioglitazone causes heart failure, but look at this. Heart failure, those who didn't have pioglitazone had more heart failure. So this analysis showed that almost 67% less mortality in patients given pioglitazone over a decade or large study. So insulin resistance and NAFLD, that is where we come to. Basically, fatty liver is because of insulin resistance. Full stop. That is the cause or the most important cause for a fatty liver. I won't go into this for time. Basically, this is the ACE endocrine practice guidelines, which said that when you look at type 2 diabetics, 90% of your type 2 diabetics will already have had a fatty liver. 37% of them will have NASH. and 20% will already have significant fibrosis. So when you talk of NASH or NAFLD or MAFLD or MASH, whichever you want to call it, your diabetic patient has it, whether you have proven it or not. And this was a study we did and published, which was done in our clinic, almost 1,500 patients. Randomly, as they walked in, we did a fibroscan for them. 75% of them had fatty liver, and 27% of them already had fibrosis, asymptomatic patients. So that is where it is. So what are the recent updates on management? Lifestyle modification, diet control, weight reduction, management of obesity, basically treating insulin resistance by either weight reduction or with drugs. That is the basic fundamental here. Now, if you look at this, weight loss, the last column says 3%. If you lose 3% weight loss, steatosis improves by 35%, 5% ballooning inflammation improvement, 7% NASH resolution, and 10% even fibrosis regression. But the sad part is, at the end of 1 year, how many patients actually can maintain that weight? In the top, less than 10% can maintain that 10% weight loss. So pharmacotherapy has come in, and now we have the GLP-1 and the co-agonist tirzepatide. Excellent weight loss figures. This is semaglutide, which has given a weight loss of almost 15%, and it shows improvement in NASH and improvement in fibrosis. And in fact, on 15th August, the US FDA has approved semaglutide 2.5 milligram for the treatment of fatty liver. So this becomes the second drug which is officially approved by US FDA for treatment of fatty liver. Tirzepatide studies are going on. Very soon, I think that also will get approved. But here they have an almost weight loss of more than 20% and 22% at the end of 72 weeks. The BMI can come down from 38 to 30, which is very, very significant. Waist circumference can come down by almost 9 inches. And if you look at MASH, yes, the MASH can improve without worsening of fibrosis, and fibrosis can improve without worsening of MASH. The enzyme levels, your SGOT-PT or ALT, comes down very significantly with these drugs. And you have another molecule which is a triple agonist, which is in the pipeline, retatrutide, which is a GLP-1, GIP, and glucagon agonist. And there, if you see at 24 weeks, there is a 80% resolution of hepatic steatosis. And that figure becomes 90% at 48 weeks. So this is in the pipeline, undergoing phase 2 and phase 3 studies. Like I just told you earlier, on August 15, 2025, semaglutide was approved by the US FDA. In India, the first drug to be approved for fatty liver was saroglitazone, based on the evidence 1, 2, and 4 studies. Basically, saroglitazone is a PPAR gamma and alpha agonist. PPAR gamma works just like pioglitazone to reduce insulin resistance. PPAR alpha reduces triglyceride level, which is a component of fatty liver. That excess triglyceride also contributes to fatty liver and has decent results. Resmetirom was the first drug to be approved by US FDA. It's a beta-selective thyroid hormone receptor agonist, which is specific and has been shown to be effective in reversing even fibrosis. And that was the reason that it was approved by US FDA. Unfortunately, extremely costly drug, not available in India and not available in most parts of the world yet. SGLT2, there are a lot of studies now coming showing that it has an improvement in fatty liver. Even on the FIB-4 score, this is a paper presented by Krishna Sheshadri from Chennai. In fact, pioglitazone, if you look at these are the benefits here, SGLT2 there, and they join together, have a beneficial effect on MASLD. Cardiovascular effect of SGLT2 and pioglitazone. If you look at it, the last line is the combined pioglitazone and SGLT2. Very good results when you combine an SGLT2 with pioglitazone in MACE, cardiovascular death, non-fatal myocardial infarction and non-fatal stroke. So that becomes a deadly combination of pioglitazone and SGLT2. The side effects of pioglitazone, like slight fluid retention, is countered by SGLT2. The weight gain of pioglitazone is countered by SGLT2, and you have a combined synergistic beneficial effect across the board in fatty liver and even in cardiovascular outcome and mortality. These are old studies before the advent of GLP-1 and or the newer molecules, which showed that for resolution of NASH, NAFLD score, or steatosis, you look at the last two columns, it is pioglitazone 30 and 45 milligrams. You look at the ACE guidelines, this was 2022, pioglitazone and GLP-1, and if you look at the last one there, it's GLP-1, pioglitazone, and SGLT2 which has come in. The ADA guideline of 2023 says pioglitazone and GLP-1 analog. This is the EASD guideline which came out in September 24. Here they talk of resmetirom, which is now approved by US FDA, and GLP-1, SGLT2, and metformin. If you look at the ADA guidelines for 2025, GLP-1, SGLT2, yes, but if you look at the last column down there, agents with potential benefit in MASLD and MASH, GLP-1 coagonist and pioglitazone in combination with GLP-1 RA and pioglitazone can be used. This is the MASLD treatment algorithm, that if you have only fibrosis 0 to 1, obesity therapy is GLP-1. But diabetes therapy is GLP-1, GIP, and pioglitazone SGLT2. If you have grade fibrosis grade 2 to grade 3, again GLP-1, GIP, okay, 2 minutes. GLP-1 RA and pioglitazone. But once it goes above that, I mean, for cirrhosis compensated, same continues, but decompensated, then you discontinue all this treatment. These are again ACE guidelines which says pioglitazone all the way. These are the treatment modalities which are available to us to treat fatty liver. Resmetirom, GLP-1, GRP, they are very expensive. Resmetirom is not available, and GLP-1 RA and GIP RA combinations are beyond the reach of 99% of our population. I would say 99.555%. So what are we left with? We are left with pioglitazone, saroglitazole, SGLT2, and vitamin E. This is what our common people will use. And here, what is the evidence? That pioglitazone has got a lot of cardiovascular evidence, and as an insulin sensitizer. The strategy. Macrovascular damage starts many years before the onset of diabetes. Microvascular complications are linked to dysglycemia. Insulin resistance and its complication in beta cell preservation have to be adequately addressed from day one of your treatment for positive long-term outcomes. And if you treat them, you will be able to prevent and minimize all diabetic complications, including fatty liver. So metformin, pioglitazone, and an SGLT2 combination is the most durable. There is no weight gain and gives the best results when there is endogenous insulin present. What does it mean? Means you start treatment on day one. You don't wait for him to be 10-year-old diabetic to start this combination. From day one you start. So metformin, pio, and SGLT2 with endogenous insulin is the best. And in fact, now you have a lot of companies who are coming out with a combination of SGLT2 and pioglitazone. So pioglitazone is a powerful metabolic agent. It's just not a glucose lowering agent, it's an anti-atherosclerotic and lot of pleiotropic effects. And there's a lot of evidence. And most important, what is highlighted in yellow is it is most suited for Indian phenotypes who have the visceral obesity, insulin resistance, and for them. And it combines all the scientific data, clinical relevance, commercial availability, cheap drug, and is not an outdated choice. Everybody thinks अरे ये तो बहुत पुराना molecule है. अरे it is the molecule. Thank you.